So if you have specific questions, please come to the mic, identify yourself, and ask your question.
Thanks for two wonderful talks. My question is for Dr. Zeisel. Steve, I was wondering, why would you bother to go through all the work of a medical food if choline could be a dietary supplement? You could just...
If it were choline alone, I agree with you, it's a nutritional solution like a dietary supplement. The advantage of a medical food is, one, there would be a physician or health professional overseeing the interpretation of the test. Two, obviously, there should be a bigger markup on a medical food. And so for the ones where you have multiple pathways disturbed, a medical food makes sense because you could fit all the definitions. For the one like the infertility one, it might not be a medical food. It might be a diet supplement based to a genetic test. Again, the reason I'm trying to think about it is I'm just trying to understand how do we get to medical foods. So, because the physicians that I'm working with, and you know, we run a large education program in nutrition throughout the country, precision medicine they understand. Gene test tells you what to prescribe. And I think we can use that in nutrition. A gene test validates that there's a problem that you're really treating, instead of the feeling of physicians that they're giving something that they don't really know is going to work. So, I think solving a real problem that you see in a gene test, just like for the consumer, makes them feel more confident. I think it'll make the medical profession more confident in prescribing the solution if it fits. And here we have a medical professional who can tell you if that's the case.
So I have a question. Claudia Morris from Emory. This may be a little bit political, but with all the discussion about pre-existing conditions and genomics, metabolomics, proteomics, how does that all fit in for the future if it's unsure whether or not pre-existing conditions are going to cause a problem for insurance for our children at this point? How would you see all of this fitting in and protecting the future?
I certainly can't speak to that. I mean, I can tell you, from my experience, one of the big barriers to medical foods is getting insurance companies to pay for these. I mean, especially for some of these kids with inflammatory bowel disorders and so forth and so on, some of them dependent on these liquid diets, for their survival. And it's very difficult for them to get the insurers to pay for these. So there is a lot of interest. There is a bill pending on the Hill. I think it's called the Medical Foods Rights Act, to begin to, have insurance pay for these various products. The question is, what is the standard of evidence going to be that justifies this huge expansion then in reimbursement? And I think that's what a lot of people are wrestling with right now, is what should be the standards of evidence that these actually work, that they're meaningful in terms of managing the diseases at hand, to then convince, the politicians to make the insurance companies pay for these. And that's something that this community is going to have to wrestle with, is what are the standards of evidence.
What I would say in terms of the pre-existing condition piece, I think that what I'm talking about is somebody already has a problem, fatty liver, rhabdomyolysis, and the physician is looking for the optimal treatment at the lowest expense. And having a test is the standard of what a physician does. You send out a test. If it comes back positive, you feel confident in prescribing something. And here we're saying we can show that people have a specific metabolic defect, and the solution is designed to treat that metabolic defect. I think that works, and it doesn't place anybody at any more risk than the diagnosis that you have fatty liver and metabolic syndrome. You're in trouble with your company anyhow if they can get rid of you for pre-existing condition. And now, one day, babies will get their genotype at birth, and your pharmacogenetics will be available immediately, right? So that when you go in and they have to prescribe warfarin to you, they won't have to do a test. It'll be on file because your genes were sequenced when you were a child, looking for rare diseases, but that data will be there. And again, there'll have to be a legislation that says having that test in place doesn't place you at a disadvantage. I'm doing a study with NASA right now. 16 of the 32 astronauts who spent more than 6 months in space lost visual acuity permanently by the time they came back. We have no idea why. NASA doesn't have an idea, and they went through all of the physical things like microgravity not draining ocular fluid, glaucoma, whatever. And the best hint so far has been that they have relatively higher homocysteines, not out of the normal range, but higher than the other astronauts who didn't, and they have some polymorphisms in one-carbon metabolism. So those astronauts don't want to get tested because the only thing in life that matters to them is not their vision, but going back up into the space station or to Mars. But for NASA, they have to figure this out because they'll never send people to Mars if they leave here seeing well and they arrive in Mars needing glasses to see things. So I think with all of the public, there is a risk to getting genetically tested. There has to be legislation or some treatment. I'm sure NASA is not going to select an astronaut once they know the genotype of the people who lose their vision because they don't want to have astronauts losing their vision on the way to Mars. So we're working with the Army about the rhabdomolysis. Special forces have to be able to undergo exercise. They have a significant portion of their developed rhabdomolysis and have to be sent home from the field. They'd like to eliminate those people. They don't, the soldiers aren't going to want to be genotyped, but if the solution is related to the genotype and we can make the problem go away, then it's worth being genotyped because you won't develop muscle breakdown.
Okay. So I'm going to ask do you have a question? Oh, okay. My first question is for Dr. Stover. And given the information that we know about the environment and also about the different polymorphisms and how that impacts how the genes expressed, what does this mean for dietary guidance? Like good old dietary guidelines. Do they still exist in this new world that we're talking about, or do we abandon that altogether and try to come up with something a little bit more progressive?
Sure. I mean, so this is really the question of really, are we talking about, the clinical nutrition, the patient, or are we talking about uses in populations? And I think the answer is both. Again, in WHO, when they came out for their recommendation for fortifying, the food supply to, prevent neural tube defects, they included in their model the effects of the MTHFR polymorphism was going to have on folate status, the prevalence of that in the population, to come up with, a range of values of fortification. So the question will always be, to what degree does any sort of a modifier or a sensitizer affect, what a requirement is for any one given nutrient, and whether or not that falls within the normal distribution, or whether it falls, you have an identifiable group that falls outside of the rest of the population distribution, and then you have to either change the value to accommodate, or come up with a framework to change the value to accommodate what is an identifiable, minority group that has this need for whatever reason. Or then you make them a different subgroup. And the question becomes, how many subgroups can you then have when you think about deriving nutritional requirements? So I think that's where the field is, and we'll see how it evolves. But there's no way that I think we're going to be able to walk away from having population-based nutritional requirements, because that's the basis of how we deal with the food supply. The question is, how do we deal with people who fall outside the distribution?
So I think that with some more human data, you could say, let's take that polymorphism that 72% of U.S. women have. That's a big enough population. So I think part of it is the size of the population effective. It's 1 out of 100,000, you might not accommodate it. But if it's half, you do want to figure out how to accommodate it. And you might have to have a genetic test that says you need more, and if we don't know it, then we cover the higher amount, but then we take the upper limit toxicity that you're pushing towards the toxic effects of the nutrient. And then in terms of numbers of groups, maybe the next step for the policy and guidelines would be to use haplotypes. There are a lot fewer haplotypes. And haplotype is a lumping of genes that tend to travel together with an ancestry, and there are a lot fewer of them that you'd have to deal with. And so you could say for a haplotype, this population that came from Europe or came from Asia that we saw in the mitochondrial migrations, et cetera, that we use the haplotype as the recommendation, and that isn't individualized, but it gets closer to the haplotype that people share.
But I think we also have to remember, especially if we're talking about a chronic disease endpoint for either dietary or nutrient guidelines, when you think about a chronic disease and what are the risk factors for a chronic disease, it's family history, which is genetics, it's age, and it's diet. And so genetics alone, you know, an aging cell, aging physiology, and aging genome has just as much effect on a chronic disease and maybe even on nutritional requirements as genetics does as well. And so I think it's important to understand what is the relative contribution of all the factors that contribute to a chronic disease and understand those, because it's not going to be the genetics alone, it's going to be the interactions between the genetics and age and diet.
Okay, got a couple of questions, thank you.
Naomi Fukugawa. So I think, well, we all know that it's a spectrum that we're dealing with. And one question, there's the wellness side of where food fits, and then there's the therapeutic side of where food fits. And how would we potentially differentiate between our classification of where a food falls, and then, you know, for example, whether or not then it becomes a supplement because it's a separate entity versus can you eat enough eggs to get the choline that you do need that you might get in a supplement?
Let me just make one point, and I know that the committee that developed the frameworks for chronic disease endpoints for DRIs, when you talk about health and wellness and disease, chronic disease initiate probably prior to conception. And so a chronic disease is a trajectory. And so you can't think about somebody being healthy and then becoming sick when you think about a chronic disease endpoint. You think about a trajectory, and that trajectory goes over time, and how fast you reach a state of chronic disease, and then how nutrition then changes or modifies that trajectory. And so, you know, the idea of the food supply and wellness doesn't align very well with the ideas that chronic disease manifest over a lifetime. So the question you ask is, what do you do when the requirements of an individual, when your endpoint is, you know, a chronic disease endpoint, when do they fall outside the realm of what one can achieve through a natural food-based diet? And we had that experiment with folate to fully prevent your risk for a neural tube defect. If you are the right person with the right genetic profile, you can't get enough folate from the food supply without fortification or without supplementation. But that's what we have to, that's exactly what we have to wrestle with, is when your requirements, you know, fall outside of what a healthy food-based diet can provide.
I think another way to think about it is that without a challenge, somebody may be phenotypically healthy, and that when they get the challenge, their genetic and other limitations that make them inefficient, let's say, in a pathway, are revealed, and then they become sick. So you wouldn't need to, for instance, for fatty liver, worry all much if the person isn't taking a lot of calories and isn't making a lot of lipid in the liver, then the transport out doesn't matter. But when it becomes important is when they're challenged. And wait for the phenotype to appear. Or you could anticipate the phenotype appearing because they are they're overweight and moving towards more. And so you'd say in overweight, there's a different requirement because their need to transport out of the liver is going to be increasing. So that's where all these other factors need to be understood to say what is the challenge that's going to reveal their problem, their metabolic inefficiency. And by understanding it with what we know in nutrition, we can do that. The bad part is we're going to miss things that we never conceived as being likely. And the other approach of just saying, let's measure everything, like the 100,000 person project, measure everything and see what we can correlate, that will reveal things we didn't anticipate being there, but the data will be more associational than if we had an understanding of the biochemistry and metabolism that led us to make that hypothesis. And what I'm suggesting is something in between, do it that way, and then ask, could you have done better? And by using other genes, and those other genes then become hypotheses that can be tested as to why did they contribute to fatty liver when I didn't anticipate they would.
Okay. I think the lady.
Yeah, thank you. Suzanne Nielsen at Purdue University. I noticed the title includes food product development in the title. You've alluded to that. You've talked about it just a bit. But I'm thinking about how the tools of the nutrigenomics types of tools will impact what kinds of food products become available, and how widely used those are, how those are touted, maybe regulations around those. I think of, for example, gluten-free has become very mainstream. And that's related to a medical condition that I presume can be predicted with these kind of tools. I'd ask you to think of just a little bit about what more might you say about food product development linked to these tools. Thank you.
So I would say that, we're at a frontier, and someday it'll be obvious how you develop foods that are not commodities, that have a little extra value because they are designed to specifically deal with a health problem, maybe based on genetics. And we're going to have a lot of snake oil, but we have a lot of snake oil diets with regular foods, right? But I think eventually if we come up with the reason I like the medical food place to start is the FDA has set some ground rules up. And they haven't fully defined them as the problem, but with what they've defined, you have at least some oversight of the rules, what you'd have to show and whatever else. But as pointed out, it's kludgy, a lot more money, and not as easy, but you need to differentiate yourself from the fact that you'll come up with an idea and some mom and pop operation who's been in business a day will copy it and sell it and ruin your reputation when it doesn't work, right? So I think medical foods would be is the reason I think that's the place to start for the food industry and companies. And then once it works, you can come back and say, how do I go over the counter like the pharma does and give it out to the whole public? But the diet supplement business is just fraught with a lot of problems. This work will require some research and some investment, so it'd be nice if you could compartmentalize into something that brings slightly higher returns to account for that extra cost.
Yeah, great talks. Really enjoyed the session. So you've kind of both talked to some degree about this notion of genetics under challenge, which I'm a big fan of as well. I think that it definitely highlights a lot, because in big GWAS studies, typically with common variants, you see something like on the order of a 1% effect is a pretty large effect. And yet we see, some examples today with much larger effects right under challenge. And so I guess a couple of questions is, to what degree, is enough of this information been cataloged or consolidated, I guess, in ways that we can learn across that? I have some personal interest in this. We build genome scale models of human metabolism, which I didn't talk about, but that simulate defects on any human enzyme, for example. But I'm very curious about just how you see the process of consolidating that information, and also how do you see us getting beyond just a few examples to being able to do that at a large scale? If that makes sense.
Sure. I think, when you go and develop the architecture of these metabolic networks, what's important to consider is, number one, from all of the available databases that are out there, from expression to SNPs to some of the splicing defects to the effects of aging, what is the range of expression? So that you have, can put a border around the magnitude and effect you can see at any one node. And that information is available, but there is, one has to have some sort of it's not readily available. It's in the literature. One has to hunt through, understand what you're looking for, have some familiarity with the field to look at, the specific papers that I've known Steve has done on, choline metabolism and so forth and so on, and then have access to those other types of omic databases that give you information either at the level of the proteome or of the transcript of what, again, the dynamic range is. And then once you know what those dynamic ranges are, you can then, through sensitivity analysis, determine what matters, what doesn't, and dial these things up and down and see how then it affects that range of responsiveness to a concentration gradient of inputs of nutrients and how they interact. But no, I don't think that there has been a good coordinated effort to really look node by node and determine what, the degree of stochasticity or of expression that's associated with each node, and that's certainly needed.
So what I would say is that this is why I think this is a collaborative type of research, that metabolomics is the same. You have experts in how to measure genes or how to measure metabolome who don't really know metabolism. And they have to be combined with people like people in nutrition or other fields where they understand metabolism, what are the inputs and outputs, what challenges the pathway, and then design, think about it. So again, when we had those liver biopsies and I was trying to figure out why some people you predicted beautifully in, then it was logical to say, well, what would place a stress on fat export? Well, obviously making more fat. And so then you said, what makes more fat? More calorie intake. My indirect marker for that, because I didn't have accurate calorie intake, it was BMI, because clearly they got a BMI by taking in more calories. And so that then worked out beautifully. So I think the same thing is to have somebody who understands enough about metabolism to say, look, I'm looking at vitamin D. What are the limitations of vitamin D? The receptor has to bind it. If it binds it worse, that would be a limitation. Or lower levels of vitamin D, it becomes important that you bind it well. At higher levels, the binding affinities are such that they'll bind. So I think it's understanding metabolism, which is the unique skill of many of the people in this discipline, needs to be combined with an understanding of what do I measure and how do I measure the genes or whatever. And if we combine the two, you come up with sensible stuff. And if you don't, you get GWAS, where it's mainly geneticists who have no understanding of biology, who are then honestly just statistically asking what's associated without realizing that they're mixing challenged and unchallenged people and finding nothing because of that.
Yes. I'm interested that one of the goals of this nutritional consideration is to minimize chronic disease. And the pharmaceutical industry would love to develop drugs that have the same effect, particularly, for example, the statins. And so what is going to happen when we have pharmaceuticals that are given to 50 or 60% of the population to minimize a chronic disease, and at the same time we're interested in thinking about nutrition and how to minimize that effect? For example, with the statins, since that inhibits the formation of coenzyme Q and cytochrome C for cytochrome C oxidase, some people take coenzyme Q10 to offset that effect. You can also get that through the diet. How are we going to manage these sort of conflicting perspectives on how to deal with chronic disease?
In terms of the effect of the treatment of chronic disease on nutrition needs, I think the FDA is very clear on that. That is, a pharmaceutical that changes your requirement for any nutrient has to become part of the drug. It doesn't become its own requirement, it becomes part of the formulation for that drug. Whether that should remain that way or not, given so many of these drugs are so widespread now in their use, that maybe that should be revisited. But, you know, that's what the way the FDA views right now how drugs affect requirement. It has to be part of the drug. The other effect is sort of the race of who's going to play the most or the biggest role in lowering rates of chronic disease. I think both have to move forward. I think that, I think a lot of the evidence is that these are diet-driven and that in the long run, the diet-driven approaches are going to be the best approaches in terms of lowering rates of chronic disease without side effects and without the added healthcare costs. But, you know, those are decisions made by politicians, not by us necessarily.
Okay. Johanna?
Tim Mork with Spectrum Nutrition. I think you're right, Steve, that medical food seems an appropriate category to be looking at, but not everybody's familiar with all the narrowness that curtails from a regulatory standpoint. So I think one thing to point out is choline is a nutrient, so at least it gets that part of that box checked, because a lot of people are trying to make medical foods out of things that aren't actually nutrients. But secondly, it's the fact that you're going through medical supervision, which I think is an appropriate approach, rather than out to consumers, because that's not indicated in the medical food regulations today. But the concept of nutrition as a broader category, I think, is where you wouldn't be allowed to say we're treating the disease. That's only allowed for drugs. You're addressing the nutritional imbalance that the patient has by virtue of a genetic condition or in some cases a disease impact that makes this imbalance. So I think it's very important to emphasize that these products are for nutritional management, and I think it calls into question, how do we talk about a balance, a normalization, if you will, a restoring of the normal metabolism, not necessarily dealing with a pathologic condition that the disease is imposing. So when we keep those in mind, I think it's always a nutritional treatment, and the reason why medical foods versus dietary supplements is dietary supplements can only help support the normal function. Medical foods are the only category that allows you to talk about the disease, the nutritional needs of a patient with a disease. So that's the attractiveness. As far as getting better reimbursement, that's still a crapshoot, and I wouldn't hold my breath on that one.
I'm not trying to suggest that medical foods is the only way we should start implementing nutrigenetics. What I'm suggesting is that if I had to, and if I want to, my best bet in my mind is to go this way to get the field started on something that will be highly credible, have science behind it, is not likely to blow up because somebody does something foolish with no regulations. And once it's there, I see you can spread it easily. And I think the same is the diet advice is a very reasonable output to it. It's just our knowledge of what diets do isn't as good as our knowledge of individual sort of metabolic pathways. So if I had to step in today, this is the easier place to be credible. And maybe in 5 years, I know enough about who loses weight and who doesn't lose weight, and I can be credible there with a different type of product. But right now, it's hard to give advice on a broader range because it's more complicated. We heard how complicated things are. I think you simplify it by staying in something you really understand well, and then say, look, I can deal with this smaller problem. Eventually, it'll build up to many products dealing with many problems. And the concept that this approach works will permeate medicine, and then they'll tell their people, go out and eat more eggs. But right now, giving eggs wouldn't appeal to a physician as much as I do a genetic test and I have something that I prescribe that makes it better.
Johanna?
Just Johanna Dwyer from the Office of Dietary Supplements. It seems like the way this is going, is that certainly clinical nutrition needs to be involved, and certainly medical supervision needs to be involved in clinical genetics. And yet, even with adults who have inborn single gene defects, inborn errors of metabolism, they're not very well handled in the great hospitals of America right now. Maybe for children they are, but for adults, they're really not integrated into internal medicine in the big departments. I don't know about the surgeons, but basically, how is this all going to be handled in this brave new world?
I think that, again, the reason I'm approaching medical foods, I think it's a concept akin to precision medicine. Every medical student now is being taught genetic test and a pharmacological intervention. Your dosing can be gotten much more precise, and I think this will be attractive because it's a similar concept. I have a test, I identify a problem, I'm sure there's a problem there because the test was positive, and now I have a treatment that seems to fit the underlying mechanisms. And for nutrition, often, the physicians don't see that it's akin to giving a drug. So I'm sure if they had a fatty liver drug, they'd do it. The reason fatty liver is a good target right now is there is no approved drug for fatty liver because they're too toxic. And so I think the point of permeating with genetics right now into medicine is because precision medicine is a powerful movement that NIH is behind, and that medicine is behind, the big medical schools. And so I think everybody will be practicing that way, and this will just look the same to them. And if we don't do it, then nutrition will be just like it always has. It doesn't fit the model, and they don't do it because it's just the nature of being a physician.
There is a model here, though, and I think, and Doug Wallace talked a little bit about this, but inborn errors of metabolism, where you have a highly penetrant single gene defect that gives you then some clinical manifestation, that can be overcome. That loss of function can be overcome in some cases with a formulated medical food, and there's a number of cases where this has been shown, but you have a loss of function because of a single gene defect. A lot of the chronic diseases of aging are due to a loss of function. They're not due to loss of a single gene, but they could be due to loss of mitochondria with an autoimmune component, with inflammation and so forth and so on, but you get the concept where you do have a loss of function. It's just multifactorial how you got to that loss of function, and that you can then develop a medical food that overcomes, just like in the inborn errors, overcomes that barrier to restore function. So I think the model is there. It's there from the inborn errors of metabolism. You just have to think about it differently from a single gene loss of function to more of a complex interaction of factors that give you a loss of function. But either way, the paradigm that you can restore that function with some sort of a different nutritional input, I think provides a good paradigm.
Okay, thank you. This was quite the session. So join me in welcoming and thanking our guests. And it's break time now, and so we can go out and talk more about this.